Hello, and thank you for joining us. The Southeast Mental Health Technology Transfer Center is pleased to present today's webinar event, Focus on the Family, using person and family-centered care for mental health. My name is Emily Moore, and joining me in moderating today's event is Dr. Benjamin Druss, Director of the Southeast Mental Health Technology Transfer Center. Before beginning, I would like to take a moment to describe the work of our center, followed by a brief introduction of today's speaker by Dr. Druss. The Southeast Mental Health Technology Transfer Center is located in Atlanta, Georgia at Emory's Rollins School of Public Health. We are proud to serve the 8 states in HHS Region 4. Our expertise in public health programs, systems, research, and evaluation provides a unique lens through which we can address mental health priorities. The goal of the Southeast MHTTC is to accelerate the adoption of evidence-based mental health programs by providing training and technical assistance to Region 4. We use a public health approach to build leadership capacity and to provide mental health trainings and resources to providers, agencies, and communities across the Southeast. We encourage you to visit our website to learn more about our center and our upcoming events. I'll now turn it over to Dr. Druss for an introduction of today's speaker.
Thanks so much, Emily, and thanks to everyone for joining today. I'm really excited to introduce our speaker, who is a friend and colleague. Teri Brister, PhD, serves as the National Director of Research and Quality Assurance at NAMI. Dr. Brister is responsible for ensuring that all content created and disseminated by NAMI attains the highest possible standards of accuracy, relevance, value, and academic rigor. She is the author of NAMI Basics and co-author of the NAMI Homefront program. Prior to joining NAMI in 2005, Dr. Brister worked for 20 years as the community mental health system in Mississippi, working in both clinical and administrative roles, including Assistant Executive Director in 2 different centers. Dr. Brister received her PhD in Public Policy and Administration from Jackson State University and her Bachelor of Science and Master of Science degrees in Counseling Psychology from the University of Southern Mississippi. She's a licensed professional counselor in Mississippi. Teri, I will turn it over to you. We're really looking forward to this.
Thank you so much, Ben. And I'm going to try to navigate sharing my screen. But before I do that, and because I'll turn my camera off when we actually get started, I very much appreciate the invitation to be able to talk to all of you today. And if you're like me, you hate sitting there listening to your bio being read or being shared. What I want you all to hear is that I'm one of you. First of all, I'm in the Southeast region. I'm still in Mississippi. I work for NAMI, which is based in Arlington, Virginia, but I work remotely from my home in Mississippi. When I say I'm one of you, not just because I'm in the Southeast, but I refer to myself sometimes in NAMI circles as a recovering mental health clinician. I don't know that you ever fully recover, but in my heart, I'm a servant of people with serious mental illness. As Dr. Druss shared, I worked in community mental health centers for a lot of years, obviously started very young since I can't possibly be that old, but worked a lot of years. I've been where you are, case manager, therapist, managing the psychiatric schedules and the nursing schedules, day treatment programs, clubhouse programs, group homes. I've been where you are. And to say you're where the rubber meets the road is really, there's no right term, but you are very frequently what stands between an individual and the family in de-escalating a crisis and in things getting drastically worse for them. So I appreciate you participating in this today, and we'll have time on the other end of the presentation for questions. So want to encourage you to submit those in chat as we go, and we will get started. Let me share my screen. Perfect. All right. So again, focus on the family. I realized as we were doing the introduction, I probably owe some kind of copyright to Dr. James Dobson, who used to do a Focus on the Family series years ago about raising children, but maybe he won't mind that I borrowed it. I'm not going to read the learning objectives for you, but I did want you to see them. And what I want to challenge you to do is, because webinars are webinars, we have to have objectives. But what I really want to let you know is that this drills down to how do you engage somebody? It can be the biggest challenge of the treatment process, whether or not they buy in, they being the individual, they being the family, but getting that buy-in and building that relationship with the individual that you're working with, it can be one of the biggest challenges in the therapeutic process, and especially if that individual has serious mental illness. Ironically, it can actually be easier to engage their family support person, whoever that happens to be, and we'll talk about that later in the presentation. And you may be sitting there shaking your head, easy for me to say, right? It can be easier to engage them once you identify them. The tough part can be identifying who that person of support is for them. So you have to be open to looking and to realizing there's somebody there and doing the work. Everybody has someone. So the way I want to approach the presentation today is kind of a rinse, repeat, if you will, if you ever read the shampoo bottles. We're going to talk about why this is important. We're going to talk about some ways to do it. And then we're going to talk again about why it's important and some different ways you can do it. So let's get started. Again, preaching to the choir here, you know about the prevalence rates, you know about the lack of access to services for a variety of reasons. There's a shortage of services. We all know that. Many of you, if not everybody on this call, would probably identify yourselves as having caseloads that are too large to manage. But even when services are available, many people don't take advantage of them for a variety of reasons. The numbers are real. Again, preaching to the choir. What does this slide say at the end of the day? It says that the more relapses that an individual has and the more times they drop out of treatment or delay getting treatment, the worse the outcomes for the individual, for the family, and for the community at the end of the day, because everybody is a member of the community that they live in. What's person-centered care? Long story short, it's all the things that are on this slide. It's pretty easy to define. You've probably all participated in some kind of a webinar or a class or written a paper on or read an article on person-centered care. It's kind of the politically correct thing to say that you do if you're a therapist or a case manager or a healthcare provider of any sort. But again, at the end of the day, what is it? It does all these things that are listed on the slide, but I want to challenge you to think about, most importantly, what it's not. It's not just a buzzword. It's not just jargon, and it's not just a treatment plan template. Because again, unless things have changed, and I've been out of the treatment provider world for about 15 years now, that's how long I've been at the national NAMI organization. But unless things have changed a lot, the templates for treatment plans vary, typically with administrators, sometimes with a new grant. But person-centered care is much more than just a model for writing a treatment plan. I want to invite you to think about it as a different way of looking at what you do and the people that you serve. If you will, think about it as a lens. Think about putting on your person-centered glasses, looking at everything that you do from a person-centered perspective. Different aspects of this, again, you can read the bullets for yourself. I'm not going to read the slides to you. This isn't rocket science. Again, if you think about the words person-centered care, the things that are listed on this slide are the things that would probably come to mind to you organically being in this field. At the end of the day, what I want you to think about is that the person and person-centered care, the true model, the person with the mental illness is a voting member of the treatment team. They don't just have a seat in the chair. They don't just have a signature on the care plan or the treatment plan, but they're a voting member. They have opinions, their opinions count. And I'm not saying it's a democracy and it's however many votes wins about whether the person is going to go to Clubhouse or whether they're going to be discharged. Not meaning it that literally, but that their voice is heard and that they feel respected when they speak up and that their thoughts and preferences are taken into consideration. It's not about who's right or who's wrong. It's not about challenging your authority as the case manager or the nurse or the therapist or whatever your role happens to be. It's not questioning or challenging authority. It's more about choice. It's about input. It's about compromise, and it's about respect. It's really about meeting people where they are. Why is it important? It's really pretty easy. Research shows and lived experience shows that it improves the quality of the services that are available. It helps people get the care that they need when they need it, and it empowers people to be more active in advocating for themselves and the services they need. If they feel comfortable and respected sharing their thoughts and opinions with you as the case manager or the therapist, and I'm assuming that's a lot of who's on the call, so please forgive me if we may also have psychiatrists, physicians, physician assistants. There may be a variety of people on the call, and we may have some administrators. But for me, some of the most valuable, and the time is all valuable, but the people who tend to spend the bulk of the time with people with serious mental illness are the case managers and the therapists who are doing those day-to-day wraparound services. And what we know is that the individual can become comfortable with you and voicing and sharing their opinions with you and feeling heard, then they're going to feel more comfortable talking with somebody who can be perceived as in more of a power position, the psychiatrist or the psychologist. So person-centered care really starts at the front door, from when they walk in the door at the clinic or the center or wherever you are. And it all comes down to offering all the services that you provide in a more person-centered, person-friendly way. What are some of the components that can impact outcomes? And again, getting to know them. It's more than just meeting them, introducing yourselves. Hello, I'm Teri. I'm your new case manager. I need you to sign these forms for me. Any changes? Taking your meds? Hearing voices? Not saying that that's what any of you are doing, but we can all get into a routine. We can all get into a pattern. I think we're doing a lot of, I'm going to get off script for just a minute. We're doing a lot of work at NAMI right now in the space of providing resources for frontline professionals, people that are working in emergency rooms, first responders, frontline wellness workers around their mental health while they're in the trenches, if you will, fighting the COVID pandemic. And it really is about looking at what the person needs, regardless of what's going on with them, and regardless of what you perceive their needs to be. And what we hear from a lot of those frontline responders is the way they're surviving is they have to not think about people as people, or they couldn't survive. I think many times, and I'm totally speaking for myself right now, in the days of the hectic scheduling and overscheduling at the community mental health centers where we were, we got busy, and you lose sight of the fact that these are people who have lives outside of your schedule. So person-centered care is really about not losing that perspective, and it can be hard to do. Some of the challenges for that are you have huge caseloads. I'm going to go to the next slide because this is some of the other things about it that can impact outcomes. But what can get in the way of this are the fact that most of you, if not all of, if you have a caseload, it's probably large. Typically, and again, unless things have changed a whole lot, if you move up into a supervisory position or a clinical director type position, and you may have a smaller caseload that never lasts for very long, your caseload almost always gets bigger than everybody intended for it to be for a variety of reasons, but it's reality. There's a ridiculous amount of paperwork. I don't care if you're in the private sector or in the public sector. If someone is paying for your services, you have a ridiculous amount of paperwork to do. And granted, I know it's not all on paper anymore. I'm old, but I'm not that old. A lot of it is electronic, but it's still very time consuming. There's a lot of administrative work in providing health care in the United States of America. The other piece is that you may have little to no training, formal training, in actually working with people with serious mental illness. I have been around a long time. I've established that already, and Dr. Druss established that in the introduction. But there's not a whole tremendous amount that's changed in the way therapists are trained in terms of working with people, and there's really not a lot of formal training at the graduate level and certainly at the undergraduate level about working with people specifically who have serious mental illness. Frequently, we get an abnormal psych course. We may get some, there may be spot courses here and there. But I personally, and I was trained a long time ago, but I was trained to work with what I refer to now as the worried well. People who pretty much had stable lives, they had jobs, they were able to take care of their families, and they had a place to live, and they had situational difficulties, if you will. And when I first walked into a community mental health center, which was for my practicum at the end of my training, I thought, who are these people and how can I possibly do anything to help them? So we know that. We have to be aware of that going in. And some of the training you got may have not been completely spot on. Not all training programs include more than a mention of person-centered care. So it may not have covered everything that would have been ideal for it to cover. So I challenge you again at the end of the day to remind yourselves of why you went into this profession. What brought you here to begin with? Because without exception, even some of the clinicians that and this is both as a supervisor and also in clinical days and also in my time at NAMI interacting with thousands of family members and individuals across the country, even people who had terrible experiences with the clinician for whatever reason, that clinician went into this work, went into this field, went into this line of service because they care about people and they really wanted to make a difference. And again, I know each of you do too, or you wouldn't be here. So this webinar is not about telling you what you've been doing wrong. It's about, and hopefully there will be things in it that you see where I do that, and you check those boxes. And that's terrific, but we can all use reminders sometimes. So I appreciate you joining today and again, accepting the challenge to view your patients and their families like this. And part of it is about changing assumptions of the providers and of clinicians and of the systems in which we work. Because let's stop for just a minute. It's more than just you as clinical providers. It can start at the front desk. One of the final straws for me, if you will, in my decision to leave the mental health system and to, quite frankly, to pursue a doctorate in public policy, because I thought maybe I can make a difference from a policy perspective. But one of the final straws for me was a day in one of our largest clinics, rural Mississippi. We would schedule at the time 6 people an hour to see our psychiatrist, 10 minutes each. And this was a day, so we had 30 people scheduled that day. People started showing up that morning. We realized that the clerical staff at the front had given all these people the wrong appointment day. Many of them had paid for rides. They'd paid for transportation to get themselves to our clinic. And our secretary said, oops, we made a mistake. Call us back later or we'll see you in 3 months. So it's that systemic bureaucratic piece that can also be a challenge. And again, it's not that certainly is one far end of a spectrum. But what I want you to see and what I'm trying to paint a picture of is that person-centered care really begins from the minute people come into your door, or people call the facility where they call. It's the answers that are left on the answer machines. It's all those things. And it really is about a system of care. And again, not going to read the slides to you, and I'm sure you've read those while I was talking and rambling on a bit. One of the questions you might be thinking right now, though, is all of this is well and good, but how do I do this if the person coming in for services is psychotic or even severely depressed to the point that they're really not able to interact socially? They're not able at that point in time to be engaged in shared decision making or in the treatment planning process. What I want you to hear is that it's a process. Recovery is a journey. It's not somewhere that you arrive. If you think about it in the substance abuse lingo, people can become sober and stop drinking, stop using a drug, stop using a chemical. They can stop today, but the recovery is a process, and maintaining that sobriety is a process. Recovery of mental illness is similar. People start treatment, we get them engaged in treatment, but their recovery, their achieving recovery, and for everybody it's a little different, is a process. We do it one step at a time, and we do it with the goal of respectful recovery always at the forefront, and looking at it through the lens that it's possible for everybody, but the road is going to look different. It's another one of the things that's so challenging about mental health services. It's so uniquely specific to the individual. So I want you to think about for just a minute the onset of psychosis, and you can substitute psychosis for a severe depression or whatever condition you want to think about, but the onset of a mental health emergency, whatever that happens to be. It may be suicidal thoughts, it may be a psychotic episode, it may be a disruptive mood episode, fill in the blank. But whatever it is that happens with that individual, I want you to think about it as a catastrophic event for the person and for the family. We're used to catastrophic events, catastrophic episodes, trauma-based therapy. Things happen. And those things that happen impact everything else in our life, or typically many things in our life. I want you to think about the onset of psychiatric symptoms or a reemergence of symptoms, if you will. But I want you to think about an episode of mental illness breakthrough as a catastrophic event for the person and the family. Now think about what you know about trauma. Think about what you know about catastrophic stressors. They're almost always unexpected. You didn't see them coming. They're unlike any previous experience we have, so we really don't know what to do about it or how to handle it. They have an intense emotional impact. And they very frequently involve a threat or danger to the person or to other people. Okay, so hang with me for just a minute. I now want to invite you to look a little further at if we view mental illnesses for the individual and the family as a catastrophic stressor, as a traumatic event, not what caused the mental illness, not what caused the symptom, but the fact that the condition is here. We can also frame it in a way that there are predictable stages of emotional reactions. Okay? Think back, way back. Most of you, I hope most of you are familiar with Elizabeth Kubler-Ross. If you're not familiar with her name, you're probably familiar with the concept that she helped originate, which was the stages of coping with death and dying, or stages of coping with grief. At NAMI, we teach individuals and family members that we go through stages ourselves in reacting and responding to mental illness in our life. First step, dealing with the catastrophic event, crisis, chaos, shock, normalizing. When somebody experiences a bout of severe depression, and you think about anybody that you've ever talked to, or if you've experienced this yourself, We typically try to talk ourselves out of that being what it is. We try to attribute it to something else. You know, it can't possibly be depression. Nobody in my family's depressed. I have nothing to be depressed about. It can't possibly be that. Or if your loved one seems to be talking to themselves, seems to be standing off, staying away. As a family member, we may try to attribute that behavior to anything. We don't want to think it's mental illness. So that's the first stage, the whole chaos and shock, and it's got to be something else. Second stage, learning to cope. We're typically angry. Why did this happen to us? We feel guilty. Why didn't I see it coming? Why didn't I do something sooner? We can resent, why us and not someone else? Why did it have to happen to me? And then ultimately starting to recognize this is what it is, and then just feeling incredibly sad that this really is what you've got to deal with. And then the third stage is moving into advocacy, learning to understand the condition, accepting that it is what it is, and advocacy, not necessarily political advocacy, but advocating for yourself or for your loved one with the treatment system or with the insurance providers, whoever it happens to be. Now, the difference between this set of stages to the stages of reaction to grief is that typically with the stages of reaction to grief, you kind of get through the stages and then you continue to move forward. What happens with mental illness is every time there's another episode of recurring symptoms or suicidal thoughts or a disruptive behavior, a problem at school, a problem at work, a problem in the family, these crises start all over again. Most of the families that I talk to around the country, they'll, I'll ask, at the end of a group or of a class, we'll ask, what stage do you think you're in? And almost without exception, they say, I'm in stage 2 most of the time, but I'm always ready to put one foot in stage 1 because I never know when the phone is going to ring and when a crisis is going to hit. So why am I spending so much time on this? It's part of the person-centered care approach, meeting people where they are. I want you to just think for a minute of what the person, what the client, what the patient may be experiencing themselves and where they may be in these stages. You may be trying to convince them that it's time for them to start going to a clubhouse or a day treatment program, and they're still in shock and trying to accept that they even have a mental illness. We have a saying at NAMI that everybody's got to be somewhere. So I just want you to think about, they may not being resistant or treatment non-adherent. They may be struggling just to cope with what's going on with them. The other kicker, let me go back, is that not everybody goes through these stages at the same time. So we're going to start talking in a minute about bringing families into the mix. And I want you to, nothing simple. You can't just follow the steps. While the individual is going through their reactions to having a mental illness, the family's going through their responses. And frequently, the individual may be in crisis, trying to figure it out and not even thinking it's really mental illness. The family may already be in stage 2. They know this is what it is. They're just trying to figure it out and sort it out. What's also very common, if there are multiple family members, in the case of a young adult with their first psychotic episode, you may have a mom and a dad, or 2 moms or 2 dads, but 2 parental figures. And one of them thinks there's no way this is mental illness, and the other totally gets it. And they're almost fighting with each other and arguing with each other about what to do. That's normal. That's typical. It's not that they're trying to be defiant or they don't want to be helpful. They don't know how. And they're trying to sort out where all of this fits into their big scheme of things for their life. So then think about the common experiences that people share about when they first enter treatment. Most of them are coming from somewhere where they felt like they've been blamed for whatever reason. Again, frequently because they didn't realize it was mental illness to begin with, or didn't realize where they were having trouble. They may have tried things that worked before, but they don't work now. That's the other kicker with mental illness, if you will, is that therapeutic processes that work in one episode may not always work the same time. It's why medications have to be changed. It's why different classes of or the same class of medications, one brand may work a little differently than another brand. It's not so much that it's trial and error, but that's what it can feel like to the individual. Well, I did this exact thing before and it didn't, and it worked, but it's not now. It must be me. It must be something I'm doing wrong. So they're dealing with grief. They're dealing with fear. The conflict and support systems, again, family members or people that they care about in their life, disagreeing about what needs to be done, and so much confusion. Think about the cognitive component of any of the mental illnesses. You're kind of in a brain fog anyway. And then all of these other complicated things going on and decisions to be made. So that was a quick summary, maybe not so quick, of why it's important. We talked about person-centered care. Now let's talk about shared decision-making. Similar, but a little bit different. Same philosophies. But you see, I start out on this one with what it's not. It's not tokenism. It's not a decoration. It's not a treatment plan template. It's a commitment at both the individual, family, and the organizational level. It really is about meeting people where they are. And when I say family, I want to clarify, I probably should have done this earlier. It doesn't have to be, and I can go back immediately in my head to people that we would see at our mental health centers. I've spent most of my time in Hattiesburg, Mississippi, and people that were in Hattiesburg, which was kind of a hub. Interstates crossed there. We were an hour from the coast, an hour and a half from New Orleans. We had a lot of transients. And we just assumed that people coming in for services, unless they came in with a family member, that they didn't have anybody, that there was nobody in their life that really cared about them or that wanted to be involved in treatment. The other thing is, it was long enough ago that we didn't really realize at that point in time how important that was. So we didn't bother looking, unfortunately. But when I say the word family in this presentation and just in general in my life these days, I'm referring to whoever is important in that person's life. It may be the next door neighbor. It may be a roommate. It may be someone from their community. It may be somebody that they meet at a food shelter or in a lunch line or at a clubhouse program. Almost everybody has somebody. We just have to ask and do the digging. Most important thing about shared decision making is, again, it's genuine, it's real. When we look at engaging the families, look, I'm ahead of myself. Here I actually define it. Ask the person, who is important for you. Frequently, again, many years ago, when I'd ask people for their emergency contact, well, I don't want you calling anybody. I don't want you talking to anybody. Well, who would you want to know if you had a heart attack? Who would you want to know if we had to carry you to the emergency room because you broke your foot? Who do you call when you really need something? And almost everybody has somebody. HIP is a big deal. You have to have a treatment release, all of those things. What I'm laying the groundwork for is talk to the individual about who is in their life. Part of what you're doing is helping them realize that they probably do have somebody. Now, there will always be people who do live on the streets, homeless people who or other individuals who really have severed all the ties with people in their life, but even they frequently have somebody that they know that's helpful for them. There's a tendency to exclude families for a lot of reasons. This person is an adult. I can't tell you, in my introduction, Dr. Dross mentioned that I wrote the NAMI Basics program, which is a curriculum that teaches parents and family caregivers of children and adolescents with mental illness how to interact with the schools, how to help take care of the kids, how to talk to providers, et cetera, et cetera. I can't tell you how many people who have, they now teach that course because their children are 18 and older, talk about the world changing when their child turned 18. that all of a sudden the same system or the same mental health center talks to them differently, interacts with them differently. So there's kind of a tendency, well, this is, this person is 31 years old, they're an adult. We shouldn't have to include their family. It's helpful. I'm just going to leave it there. It's helpful. Family conflict is frequently present. That's the truth. It is. It's part of the illness. It's part of the consequences of the illness. And a lot of it goes back to those stages I mentioned to you earlier. Everybody is in a different place in trying to sort this out in their head and make sense of the chaos that's happening at their house. Practitioners frequently align with families. That can happen, if the family's easy to work with and the individual maybe not so much. So that's something families, the support system, whoever that happens to be, can be a core long-term resource. They're not going to go away for the most part. They're here in some way, form, or fashion. They are here. How do you engage? Again, and I'm mindful of time because I want to make sure we have time for questions. These are the basics of what you do. It's reaching out. It's making the connection. It's letting the individual that you're talking with and whoever's involved with them know that you're there. It's not opening the door and giving them your cell phone number and saying, call me 24/7. That's not necessary. But let them know when they can call you, when they can connect, what they should expect from you, and that you care about what's going on with them. If you look at that, I think it's the 5th bullet, connecting the dots, helping them connect the dots, not just between what they want and need and what opportunities are available, but helping them connect the dots, period. Our healthcare system is fragmented in this country, and so is our mental health care system. If you even, you could debate whether or not we truly have a system. It's different in every community almost, and it certainly varies from state to state. And it can be hard to navigate. See yourself as a connector, not that you have to do everything for the individual, but helping them figure out where it is. Where do they go to find it? Helping them navigate, if you will. Potential barriers to engagement, again, and these are on the part of the clinician, not the individual. These are systems type barriers. It takes a whole lot more energy to be creative and to be innovative. It takes a whole lot more energy to reach out and to I don't want to say go the extra mile, because it's not so much that, and it's not that we don't always try to do the best that we can, but sometimes it's that extra effort that for example, looking to find who is the important person in their life. Asking the questions, continuing to ask the questions, not asking in the intake and then never asking again. There can be a tendency for systems. And I say systems because it's not so much that things are set up operationally this way, but it can happen as systems, treatment programs evolve, that we become more deficits based than strengths based. And part of that, again, is the nature of the beast in terms of healthcare, that we have to deal with the pressing issues. We have to deal with negative things that are going on. We have to respond to those. To the side and don't take quite the priority. So we have to be aware of that. Working across diverse cultures is the $64 million question. Reaching diverse cultures, being not just aware, but it's actually being culturally competent. I can't tell you, and again, you're all from or most of you probably are in the Southeastern region. I've actually had people tell me in different parts of the country that they never expected to learn something from somebody who lived in Mississippi. Our ethnicity, it's the communities that we live in. And it's as, as someone who's not in their gosh, I don't even want to talk about ages, but I'm not where I used to be. You know, young adults would look at me with, you know, kind of a squinted eye if I tried to tell them or tried to let them know that I understood where they were coming from. So cultures can mean so many different things, and it's always something that we have to be aware of. Rigid adherence to program rules and regulations. It's so easy, and unfortunately almost natural. Um, it can be easy. I shouldn't say it's so easy. It can be easy, and it can happen naturally to almost hide behind the organization's rules. You know, well, we can't do this, or we can't do that, or we have HIPAA, we can't talk to anybody else. HIPAA's a real thing, and it's important. Confidentiality is extremely important, but so is helping the individual have access to everything they need, including the support of somebody else who's someone that they love and care about. So there are ways to not go around the rules, but there are ways to, and it gets back to that first bullet about getting creative and innovative, with working with the individual to identify someone of support, of a familial type relationship to be involved. Inability to convey a sense of hope for recovery and achieving life goals. That's a potential barrier to engagement. But again, I don't see that as something that's prevalent. It's certainly not something that we actively see. It may happen. It's easy to become jaded. It's easy to become burned out in healthcare. But it's so just be aware that there are things that can happen. Stages of engagement, again, it's everywhere. You know, you're not just engaging people when they first come into treatment, but if they're entering the treatment planning space, or when it's time for them to meet the psychiatrist, or when it's time for them to be evaluated by the psychologist, when it's time for something different. So engagement doesn't just happen once. It's keeping somebody interested. It's keeping them, helping them continue to understand the importance of staying involved in the treatment process. Because again, remember, recovery is a process. It doesn't happen immediately, and it's not automatic. One of the most frustrating things, one of the things I hear from families and from individuals, you know, and currently, I'm not aware of any cures for mental illnesses. There are effective treatments. There is recovery that's possible, but it's got to be tended. It has to be tended, and I didn't say managed, but it's something that we have to pay attention to. The individual, the family, and it's the treatment team's responsibility to help them understand that. So again, engagement is more than just at the beginning. It's keeping the individual interested and helping the family or the support system understand why this is an ongoing process and why it doesn't have a hard end. Okay. It's hard because the first thing people want when they're in crisis, family members and individuals, is what's the prognosis? You know, you break your leg, you go to an emergency department anywhere in this country, and there's a standard of care. You leave it ends in you leaving whatever facility you're in with a cast or a boot or a brace or a whatever, and an instruction sheet that tells you exactly, you know, what do you do if you itch? What do you do if you hurt? What do you do if it burns? How do you wash it? When does all this come off? When does it change? And when are you going to be 100% healed? You walk out knowing that. Unfortunately, if you experience a psychiatric emergency and need emergency care, you could end up in a jail. You could end up in handcuffs. I mean, we don't have that system. So it really is helping the individuals and the family understand why it's an ongoing being mindful process. NAMI actually developed something that we call our engagement report several years ago. It's available on our website. I just put it up here so that you can see it because I want to walk you through, and this was where we convened a national group of experts, treatment providers, family members, individuals living with mental illness, some policymakers. It was a spectrum of people, and put them together for 2 days to talk about what is this thing called engagement. You know, why is it important and what's really at the core of how do you make it happen? And they came up with 12 principles, which I really think are spot on. Prioritize it at all levels. Prioritizing engagement at training levels, payment levels, and measurement. You know, evaluating how engaged a person is, how engaged is the family, how involved are they? It's always communicating hope, sharing information and decision-making. That's what we've spent the bulk of the time talking about, what that looks like and what it doesn't look like. Treating people with respect and dignity, using a strengths-based approach, recognizing the role of the community. Again, it's more than just what the individual comes to you with at your center or what you see in them when you go to a home visit. It's engaging somebody as looking at who they are as a person, a whole person, not just in that 45 minutes or that 50 minutes that you're with them. It's providing meaningful peer and family involvement in the design of your treatment system so that it's not unusual if a family member comes in with their loved one. I remember clearly as a family member going to an emergency appointment with a psychiatrist with a family member and sitting and she was terrified. And we didn't know if she was going to have to be hospitalized. And remember, I'm in Mississippi. I know a lot of the people in the treatment systems. Took us 6 weeks to get an appointment, even though it was a crisis. We're in the waiting room, waiting on the appointment. My husband is a psychiatrist. That's important for you to hear. So his peers, the psychiatrist comes out and invites my family member back, and I stand up to go with them. And he says, "No, we don't need you right now." And I said, "Well, I think they want me to come." And my loved one is shaking their head. And he said, "Nope, if I need you, I'll call you." And I was dismissed. And that was it was about 1.5 years ago. So it hasn't been that long ago. So it really is setting the tone for it being expected that there's a support person involved, not treating it as unnecessary. Promoting collaboration. Last but not least, peer support services. We haven't talked about that at all today, but peer support is tremendously important. And it really is at the crux of what NAMI does. And again, I'm mindful of time. It's really at the crux of what NAMI does. Now, let me back up a minute. Here we're talking about peer support specialists. There are family support specialists, but there's something about hearing recommendations, advice, guidance from somebody who's been there, done that carries so much weight than hearing the exact same thing from somebody who has a degree hanging on their wall but hasn't walked the walk before. And that's really at the crux of why peer support specialists are so tremendously effective. What NAMI does, and I don't want to turn this into a NAMI commercial, so I promise Emily and Dr. Dress, I'm going to fly through these slides. But what I want you to hear is, regardless of where you are, NAMI, the National Alliance of Mental Illness, think about it when I used to try to explain it to my family about what I did, I said, think about it like the Heart Association, but for people with mental illnesses. We have state organizations, we have local organizations. There are 650 different NAMI organizations across the country. We offer free education and support services for people with mental illness and their families. This is not to replace therapy. We don't bash therapists. We don't teach them how to argue with you. We help teach them how to be better consumers of mental health services, quite frankly. We help teach them about the illnesses. We teach them about the treatments. We help teach them the importance of meeting you when you try to engage with them. So I would also encourage you to consider, if you're not already aware of what's available from the NAMI in your community. And if you don't know, you can go to our website, nami.org, find your local NAMI, and it will let you know who's the closest to you. But these are very much complementary services to what you do. Again, these are the kinds of outcomes that we measure. I can't remember if it was in my bio or not, but I'm actually part of SMI Advisor. Along with Dr. Druss. That's how I first met him. We are part of this initiative, SAMHSA funded, very similar to the MHTTCs, where there are all of these resources available to you as clinicians now to help you learn how to do better at what you do, to give you additional resources and support, working with people who have the most severe illnesses. And one of the perks of SMI Advisor, and I don't have the web link on there, but it literally is smiadvisor.org, is you can actually submit case consults and get suggestions from someone on the clinic. Starting about, I guess we're in the third year now. Des Moines University Medical School actually has this training included as part of their required curriculum for third year medical students. So even for people who aren't going into psychiatry, learning how to meet people where they are who have mental illness and work with them effectively. So not going to go into the details of that. Here are some, and I'll probably leave this link up, Emily, if that's okay, while we do Q&A. And that way, these are some of the sources that I used for preparing the presentation. If you want more information on shared decision-making or person-centered planning, also, you can find a lot of additional resources and some recorded webinars on this topic on the SMI Advisor site. And with that, Emily, we can start doing questions if you're ready for that.
Awesome, we are ready. Thank you so much, Dr. Brister. It looks like we already have 2 questions in the Q&A queue. So just to let everyone know, we've reached the Q&A portion of today's webinar. Please feel free to submit your questions by typing them into that Q&A feature at the bottom of your screen. The first question that I have is, how can I apply this to the school setting and building communication with parents?
That is a wonderful question. NAMI has 3, again, to be an infomercial for a second, we have 3 primary goals for our current strategic plan. One is getting people help earlier. We know that the earlier we identify the symptoms of something going on and early intervention, the better the outcomes are going to be. You could and part of this is, again, when you get into a school system, it gets a little tricky because you have to have your administrators support. And that's probably where I would start. If you're a therapist in a school or if you're a psychologist in a school, talk with your administrator, see how supportive they are to the idea of you trying to engage family members, having NAMI basics classes available. And you don't have to do them at the school. They don't cost the school anything, but letting families of at your school system know that where they can go to learn more. And there are ways to do it without getting into, and again, just being completely frank here, many schools are reluctant because they don't want to increase the number of kids who are identified, because then if they qualify for special education, they have to pay for those services. But there are ways to do this in an overall wellness process that mental health is part of our overall focus on children's health. And especially during the pandemic, with all of the virtual, we've actually got a couple of good recorded webinars on NAMI's website on kids' mental health issues during the pandemic. But it's really starting with your administrator and getting on solid footing about how proactive you can be. There are a variety of presentation programs that you could make available for faculty as well as for the family members. But it still is very much about meeting them where they are. I think about IEP meetings. Think about the IEP meetings like we've talked about treatment planning meetings, that the parent has a voting seat at the table. They're not just there because they have to be. So I hope that helps a little bit.
Wonderful, thanks so much. Our next question is a little bit longer, so I'll read the entire thing and then we can go piece by piece. But under the person-centered care approach, how would you clinically navigate telehealth for those with anxiety that don't want to come in? The mental health practitioner deems investment in treatment would be reflected by at least doing the intake face-to-face and allow a therapeutic rapport, as well as having a backup of telehealth as an option if client cannot handle face-to-face. Also considering if telehealth is not successful and there is a bad experience of treatment, which could keep the individual from seeking services in the future. So just to reiterate that first part, under the person-centered care approach, how would you clinically navigate telehealth for those with anxiety that don't want to come in?
So that was a long question. So thank you for that, Emily. And thank you for whoever submitted the question, because you've obviously given this a lot of thought. And the questions around telehealth have changed tremendously from where they were a year ago, where it was something that was optional. There was so much more debate, if you will. Views have changed on telehealth during the pandemic. They just have, because for so many, that was all that there was. So I don't have a solid answer. Let me share some thoughts, if that's okay. Telehealth can be having it as an option for, and again, I think it's much more of an option now than it should be, even than it used to be, even as services have opened back up. And I think that's one of the silver linings that's going to come out of this pandemic, is that payers as well as providers are going to be more open to using telehealth than they were pre-pandemic, because we've seen that it can work, it can be effective. So for somebody who has anxiety and doesn't really want to, isn't comfortable coming out, I have a father who isn't comfortable seeing his provider right now. I'm negotiating with them about doing telehealth with him for physical issues, but you can still be person-centered with telehealth. What I've seen firsthand, I mentioned that my husband's a psychiatrist, so he's in the other end of the house and seeing people remotely during this pandemic time. He refused to do telehealth before. He wouldn't do telemedicine. He didn't believe it. Didn't believe he could be effective with people. And I've seen his views change. The other thing I've seen is he's been able to interact with family members that he wasn't able to interact with before, because they weren't able to come into the clinic to see them. So it's possible to be person-centered, even in a virtual setting. Again, it may take a little bit more work to be engaging, but it's possible. And again, I think that's one of the silver linings in the pandemic, is that these options are not going to be as difficult to get paid for, to get approved by payers and managed care companies as they were before. So I'm hopeful that it's going to be a tool that's more available in arsenals. Hope that helps a little bit.
All right, thank you so much, Dr. Brister. It looks like we only have about 2 minutes remaining, so we need to move on to the evaluation portion of today's presentation. Do you have any closing remarks or comments before I move to the evaluation slide?
I do not, but I appreciate all of you joining. And if there's anything I can do for any of you going forward, just be in touch with the center and they can connect you with me. Thank you so much.
All right, wonderful. Thank you so much. The Southeast MHTTC would like to thank you for your participation in today's event. We value your feedback and invite you to evaluate this event by completing the brief SAMHSA required survey, which you can find at the link presented on your screen. Completion of this survey will provide information to SAMHSA and assist us in planning future events. Afterwards, you will be automatically redirected to additional questions from the Southeast MHTTC regarding the impact of this event on your knowledge and skills. There, you will have the opportunity to download a certificate of attendance for your records. Please allow about 5 to 10 seconds for your browser to redirect you. Again, our center appreciates your participation and feedback. We hope that you'll join us for future events. Please visit our website to learn more. And that is going to conclude today's presentation. I'm also going to paste the link into the chat just for ease so that everybody can access that. And once you filled out that evaluation, everyone, thank you so much. That is going to conclude today's webinar. Thank you so much.